Myself is Dr. Dnyanoba Bhaskar. So today I will give input about the established cardiovascular disease in type 2 diabetes. So to discuss, we'll take one case. He is a 53 years old corporate executive diagnosed with type 2 diabetes 6 months back. When he came for routine checkup, he complained of weakness. His family history was positive for hypertension and myocardial infarction, a heavy smoker for almost 30 years, and he quit 5 years ago and has been trying to lead a healthier lifestyle. History of previous myocardial infarction 3 years back. On physical examination, his weight is 92 kg and his BMI is 30.7. So he is obese patient. His blood pressure is 140 by 90 mm of Hg. Laboratory evaluation reveals HbA1c 8.4%. LDL cholesterol is 137. LDL cholesterol is 37. Serum triglyceride is 156 milligram per deciliter. And his renal function test shows eGFR 65 ml per minute per 1.73 meter square. And EVCR is 50. So his drug history shows he was taking metformin 1 gram twice daily, telmisartan 40 milligram OD, atorvastatin 10 milligram OD, then amlodipine 5 milligram once a day, aspirin 75 milligram OD, clopidogrel 75 milligram daily. So patient-centric approach to management is mainly focusing on cardiovascular protection, microvascular protection, weight reduction, reach glycemic goal with no hypo event, and convenient dose schedule. So primary consideration is cardioprotection and optimize glycemic control for cardiovascular risk reduction and address any weight loss issues. By adding SGLT2 plus DPP4 inhibitor combination, so it gives some important benefits. So benefits received are cardiorenal protection, simple regimen, early and durable, achieving the glycemic goal more than one. Weight loss and less is a leading cause of morbidity and mortality in adults with type 2 diabetes patients, with its onset estimated to occur 12 to 15 years earlier in people suffering with type 2 diabetes mellitus. The excess risk for ASCVD in patients with type 2 diabetes has been estimated to be at least twice that of those without diabetes. So Framingham Offspring study suggested two-thirds of patients of DM have subclinical cardiovascular disease. Increased diabetes mellitus increases the risk of subclinical CVD by 4.3 fold, and subclinical CVD increases the risk of cardiovascular events by 2-fold. The vascular wall in patients with diabetes is well known to have advanced atherosclerosis. EMPA heart study, that is effects of empagliflozin on cardiac structure, function, and circulating biomarkers in patients with type 2 diabetes, in patients with type 2 DM, showed that empagliflozin resulted in early and significant reduction in left ventricular mass regression, as detected by cardiac magnetic resonance imaging, and also suggest reverse cardiac remodeling may be a possible contributor to the cardioprotective effects of SGLT2 inhibitors. In 2015, the era of evolving dimension of cardiovascular care in type 2 diabetes management began with empiric outcome study which demonstrated significant benefits of empagliflozin for cardiovascular mortality by 38% CV events as well as MACE in type 2 diabetic patients and cardiovascular disease. All types of cardiovascular deaths were reduced with empagliflozin. More prominent absolute benefits were observed for heart failure-related deaths and sudden deaths. The post-hoc analysis of empiric demonstrated consistent cardiovascular mortality benefit irrespective of prior cardiovascular events like MI and stroke. Heart burden, CKD baseline, HbA1c level, control of multiple cardiovascular risk factors, or background use of metformin. Several mechanisms have been proposed for cardiovascular effects of SGLT2 inhibitors. including osmotic diuresis and natriuresis, leading to blood pressure lowering, decrease in arterial stiffness and vascular resistance, decrease in weight, and decrease in uric acid and oxidative stress. It has been reported that SGLT2 inhibitors promote reverse cardiac remodeling, improve myocardial energetics, and filling conditions. It also reduces LV wall stress and mass and reduce blood pressure and arterial stiffness. The EMPA Heart CardioLink 6 study demonstrated that empagliflozin could produce early and reverse cardiac remodeling in type 2 diabetes patients and stable coronary artery disease. In Carmelina and Carolina trials, linagliptin has also demonstrated cardiovascular and renal safety, that is secondary endpoints of linagliptin versus placebo or active comparator when added to standard care in patients with type 2 DM who were at high risk of vascular complications. Yampalina combination is available as a first-in-class treatment in SGLT2 and DP4 combination in group of drugs. At week 24, Yampalina combination in 25 and 5 milligrams showed statistically significant HbA1c reduction from baseline and add-on to metformin. HbA1c decrements by Yampalina has demonstrated 1.81% HbA1c reduction at HbA1c baseline at 24 weeks. The combination offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain in patients with high baseline HbA1c level together with cardioprotective benefits in patients. Thank you very much.